Hello, students. We are going to be covering information for the third exam. So let me share my screen for you so you can look along with me. So we're going to be first looking at the concept of perfusion. So the first thing we have to remember is the pathway of the blood in the heart, right? That it collects deoxygenated blood comes from the superior and inferior, goes to the, I'm dragging this along. It goes to the right side of the heart, and then it goes up to the lungs to collect oxygen, comes back to the left side, and eventually is pumped to the body through the aorta. Also, remember we mentioned the atria. When it has problems, it's not as bad as the ventricles. Also, right-sided heart failure is not as bad as left-sided heart failure. Remember the difference between the coronary system and the systemic, and how that are within the blood vessel goes to the lungs and to the body, but it does not pump to itself. And what gets blood to the heart so that it can function properly are the coronary arteries. Also remember the dynamic between the heart rate and the stroke volume and how together they help cardiac output. Remember the definitions and how they work together to do that. Remember ejection fraction and definition, how we never really get everything out of the ventricles. Not all the blood is pushed out all at once. There's always a little bit of something left behind. Also remember the definitions here of preload and afterload contractility, and we also mentioned the heart rate, but especially the preload and afterload, right? Remember the preload is the volume of the blood that the ventricle is able to hold during diastole. So when diastole is relaxing, when the heart is relaxing and the blood is filling in the atrium or the ventricles, that is diastole, right? Before the contractions happen, we have diastole. We have preload, and the afterload is the tension developed by the heart during contraction. So the pressure, the tension that the heart has to overcome, has to push against in order to get the blood going, right? Get the cardiac is the afterload. Also, we mentioned before with the with the plumbing system, how the blood flows, but now we're going to talk about the electrical system, right? The circulatory system is the blood flowing through the blood vessels, the heart, the body. But now we need to talk about the signals. Remember we mentioned that the heart, if you take it out of the body and put it on the table, it can beat on its own. And it does that without any connection to anything else. It does it because it's automatic, right? It has automaticity is what we call it. And it happens because of these electrical impulses that we've been talking about with the SA node, which is the initiator. It is a pacemaker, and it beats from 60 to 100 beats per minute. And we also talked about the AV node is the next signal receiver after the SA node, and the AV node beats from 40 to 60 beats per minute. Then the AV node sends signals to the bundle of His, and then the Purkinje's fibers. And if the SA node or the AV node are not working, then we're not going to have a properly functioning heart. We're going to need a pacemaker. We said if the SA node doesn't work, the AV node can take up the job and still have the person's heart beating at a rate that is viable, that is compatible with life. But if both the SA node and the AV node are not working, the person cannot survive. So they need a pacemaker, right? We also talked about where if we had a pacemaker in, where it would be located, right? It would be located in the chest, and it will be signaling the SA node. It could also signal the AV node. If it's signaling the SA node, we know it's pacing the atrium because this is where the SA node is. If it is pacing the ventricles down here, it is sending signals to the AV node because we see the AV node is what sends the signal to the atrium. The SA node sends it to the SA node sends it to the atrium, and the AV node sends it to the ventricles. So we have to remember that. We also mentioned that there are electrolytes that move in and out of the cell that allows for action potential. And the heart is this all or nothing mechanism, but we're not covering that for the exam, but it is nice to know information, and you will eventually have to learn it if you're needing to understand how the medications work, why we give calcium channel blockers, why we have potassium sparing diuretics. All these things are important, and you can see where they come into play, right? Sodium sparing or aldosterone, all of these electrolytes that we talk about when we mention perfusion in the heart, we see where they're coming from, right? Then we talked about the actual PQRST wave, which is extremely important for you to remember. You have to remember what P stands for. P is the depolarization of the atria, QRS is the repolarization of the ventricles, and QRS is the depolarization of the ventricles, and T is the repolarization of the ventricles. Those are things that you have to know, right? You don't have to focus on the PR interval or the QRS, or the, what is the other one? ST interval or ST segment. For the PR interval, at some point when you're going to do telemetry, if that's going to be your field of practice, that's going to be important for you. But for our purposes on the exam, you don't have to focus on it. We also talked about measurements and how we can identify the strips and what kind of EKG that we're seeing and what's happening. We also kind of mentioned ST elevation, ST depression, what it means, whether a person has an ST, an MI with the or a heart attack where the ST is elevated, or if the ST is depressed. We kind of mentioned that as well, but that's all nice to know information. You do need to know modifiable factors, risk factors that are affecting perfusion, how the person is living their life, their lifestyle, whether they have hypertension, whether they have hyperlipidemia, obesity, diabetes, stress, alcohol intake. So for lifestyle, we're thinking about, is the person, sedentary, not doing much, not performing too much activities? Are they, anything that has to do with life per se, their lifestyle, how they live their life, if they're active or not, that kind of thing. Hypertension, we also know that hypertension affects blood vessels. The heart pumps within blood vessels. So if a person has hypertension where there's constant pressure on the blood vessels, it's going to wear out the blood vessels. So we're going to have a problem there. We also mentioned hyperlipidemia when we said that we're going to monitor the cholesterol, we're going to monitor the fat that is going to possibly build up in the coronary arteries. And so we don't want that to happen. And so person has to monitor their triglycerides, monitor their cholesterol, monitor their food intake, carbohydrates, fats, all of that, right? We talked about obesity. We mentioned hyperlipidemia, that's fat. We're looking at the HDLs, the LDLs, all of that. Diabetes, we talked about how the arteries are affected, and there are arteries everywhere. There are macro blood vessels, there are micro blood vessels. They affect macro organs and micro organs. We talked about that. So about stress and how that fight or flight mechanism that a person is going through on a daily basis can definitely affect the way their blood is being pumped throughout their body. Talk about alcohol intake. Smoking is also a factor as well. For the laboratory diagnosis, we're looking at definitely troponin. We mentioned that. That's an important fact to remember. We said that there are enzymes that are released when the heart is damaged, and it tells the body or tells us who are checking diagnosis something happened, and they stay within the bloodstream for hours to days, and troponin is the one that stays the longest. So a person can possibly have a damage to the heart, some minor heart attack, and days later, after they start not having the best quality of life, they go to the hospital and they tell them that they had a mini heart attack, right? And so that's going to be something to remember. Diagnostics, we talked about a few of these. Definitely have to remember EKG, right? Because we talk about the strips, you're going to have to memorize or remember how to calculate what the strips look like. We talked about catheterization and how if a person has clotting, not clotting, has reduction in passage of the arteries, they're going to have to go in with a cardiac catheter to look to see how occluded the vessel is. And if it's more than 70%, they're going to do something. They're going to put a stent in and try to manage to open it up so more fluid can pass through. Okay. Echocardiogram, we talked about the stress test. And that is about all to remember for perfusion. Of course, anything that we read in the book is full game. Let us move on to dysrhythmia 1. So with dysrhythmia 1, we go back into thinking about our PQRST, right? We're looking to see, hold on, let me make this just a little bigger. So we are remembering that P wave stands for depolarized atria, QRS stands for depolarized ventricles, and the T stands for repolarization of the ventricles. So when we're looking at the EKG, we remember I mentioned that any problem that happens in the atria will affect the P. Any problem that happens in the ventricles will affect the Q. When the atria is affected, on the EKG, you might not necessarily see any change in the QRS. But when the ventricles are affected and the QRS shifts and gets wider, you will most likely see also a change in the P wave, right? So let's go on and see more on this. Here we talked about the absolute refractory period, the relative refractory, which means that a signal to initiate a pulse does not come in during the absolute refractory period, meaning it doesn't allow any signal, no additional beat happens here. The relative, it can allow something to come through. So we talked about the different measurements of how you can find out what kind of strip that you have in your hand. I'm not going to focus on it. You can definitely go ahead and revisit the video. But we know there's a 6-second method, the 300 method, and the 1500. And what I recommend is honestly that you memorize what the strips look like. But if you cannot, and you are able to remember this, I recommend as soon as you get your scrap paper, you write down the formulas so that you can perform, figure it out once you do see the strip so that you're not tripping over which one is what and what formula does what. Okay, so go ahead and listen to this video, watch this video again about how to calculate the 1500 rule and also the 300 rule. Okay, I'm not going to go over that with you. This is an example of a normal sinus rhythm. You have to kind of keep this one in your head because this is the basis that you're going on. Everything that looks different from this is abnormal, is an arrhythmia, right? Look at the connection or the distances between the R waves. Look at how the P wave is crisp, the T wave is visible, QRS comes up and down, right? It's really important to see that. So let's analyze some rhythms. We talked about the irregularity, all of that. This is a normal. And also remember, I mentioned it's important to know what the numbers are. It's important to know what the picture is, right? And for normal sinus rhythm, they won't ask you as much, right? But remember that if anybody is in a normal sinus rhythm, obviously you're not going to do anything because that's how they're supposed to be. So don't get tripped up if anyone tells you, if a person is in a sinus rhythm, what do you do? The answer is nothing, okay? So, however, if a person has sinus bradycardia, as you can see, the P waves are visible. The R waves are very distant from each other. The QRS is there, the T is there. So it is sinus rhythm because you see PQRST, but it's Brady because the distance between the R waves are very far from each other, right? So the most important thing to remember about this is that this is a tortoise, right? This is a slow heartbeat, and we got to get this person out of this. We're going to give them IV atropine in order to get them out of this rhythm. If the IV atropine does not work, we're going to do a pacemaker. We're going to get them out or if they're constantly, I should say, if they're constantly in this sinus bradycardia and they can't seem to kick it, they can't seem to get out of it, or every time they do, they go right back in, they might have to pace them, right? Moving on, the next one is tachycardia. We see the R waves are very close to each other, so it's super fast. Again, we see the P, we see QRS, we see T. So that's not a problem with irregularity or any distance or invisible curves. Everything is there. It's just super fast. What are you going to do? We are going to monitor them, resolve if there's a problem that we know we're going to resolve the problem, underlying cause, but we also might give beta blockers or anything that can slow the rhythm down. Moving on to more issues, we have PAC. And what that means is just that the atria contracted sooner than it should. So you see, this is normal to this is normal to this is normal. But this one starts just a little sooner. This one starts just a little sooner, right? So what are we going to do for a person with PAC? We are, if they have a run, we're going to give them amiodarone. A run means that there's multiple of these, right? So they're really close to each other. Then it gets to be regular again. Then it starts again. So this is not a run. One happens here. These two are normal. Another one happens. This is not called a run. A run is when one of this is right next to the other one. And then it starts to go back to normal again. So what are we going to do? We said the amiodarone, right? So then we have SVT. As you can see, we don't see the P wave here. Right, it kind of looks like sinus tachy, but it's not because we see the T wave, but we don't see the P wave. And what do we do? If it's stable, we're giving adenosine. If it's unstable, we're cardioverting them. And remember, as we mentioned cardioversion, that the biggest issue is that this person is, we know they have a pulse and they're doing relatively okay. Even though they're unstable, they're not near death, right? So we're going to do cardioversion. If they were near death, we're going to see we would have done defibrillation instead. Then we look at atrial flutter. Atrial flutter, we see there's smooth P waves, but there are quite a few of them. Rather than a crisp P wave or crisp contraction, we have multiple flutters, and that's not a good thing, right? Multiple smooth looking sawtooth butterfly wing flaps, right? So this is atrial flutter. This is really easy for you to just look at it and try to remember. But if you can't, then you're going to measure and see the distance between P, the QRS, all of that, right? But I recommend that you just try to remember it. Also remember what you're supposed to do, right? So if it's an atrial flutter, the treatment is, if they're stable, you anticoagulate them, which means you're giving them heparin, you're giving them Plavix, you're giving them anything that's going, Coumadin, to help thin the blood so that it doesn't clot, right? But if they are unstable, you're giving them amiodarone. You're also cardioverting them as well. No, not this one. You're not cardioverting this one. You are doing a catheter ablation if there's a problem. Now, the atrial fibrillation is where you're going to do the cardioversion. So you're doing a cardioversion for atrial fibrillation, right? You're looking to see, what does it look like? It has a similar QRS, but the P's are so zigzaggy. They're not smooth. They're really undefined, unpredictable waves, and that's more dangerous than the flutter. So this is not a good thing. We want to, again, cardiovert them. If they're stable, we're just doing anticoagulation, right? And that is for dysrhythmia 1. So now let's get into dysrhythmia 2. With dysrhythmia 2, the most important thing to know, ventricle issues are worse than atrial issues, right? We mentioned that. So here we have premature ventricular contraction. So we see in our picture here that the atrial contraction is messed up. We can't see it, right? So we had mentioned that anytime we have atrial problems, ventricles are not affected. But whenever we have ventricle problems, atria are affected. So you don't see a P wave, but you see this wide QRS. That's how you know it's a ventricular problem. So what are we doing? We're monitoring the patient. looking for warning signs. We don't want them to go into ventricular tachycardia. So too many PVCs together can cause ventricular tachycardia. That is something you have to remember. So we're treating the underlying cause, right? And we're telling them to change their lifestyle, and we're giving them antiarrhythmic medication. VTAC is this iconic looking structure here, right? It's just this wide, big QRS, right? It's like this is a big QRS, it's a big QRS, and there's no T. And the problem is, first of all, it's really fast. And second of all, it's not contracting. It's not allowing the heart to fill enough or contract well enough to get any blood out. So this is very dangerous, right? We want to get the person out of this really fast. Okay, so this is ventricular tachycardia is extremely unstable, and so we want to get them out as soon as we possibly can. So the biggest thing that we're looking at is as I said, the QRS wave, right? We see these wordings here, QRS wide, greater than 0.12. All the previous ones were less than 0.12 seconds, right? So we're looking at whether the person has a pulse or doesn't have a pulse. If they have a pulse, that means they're stable. If they don't have a pulse, that means they're unstable, okay? Then we have ventricular fibrillation. So with ventricular fibrillation, we definitely need to get this person out. They are heading towards a flat line. We talked about fine, we talked about coarse. Coarse means the wiggly, squiggly, undefined line are a little higher than this line here. This is a fine. And all it means is the coarse has been there a short amount of time and the fine has been there for a long amount of time. So for ventricular fibrillation, we are defibrillating them, right? We're defibrillating them. If they need to, we have to do CPR on them, right? And we want to get them out of this rhythm. And then we see asystole. This is what we're trying to prevent. We're pulseless, what is it? Pulseless electrical activity, I believe, PE. Stands for pulseless electrical activity, yes. So we're not loving this. We can see P waves, but P waves don't do anything for us. It is the ventricles that we want to contract. So this is asystole, this is bad. Obviously, as I mentioned in class, you still want to do some work because you're a nurse, you're not a doctor, you're not going to call the person deceased and declare them dead. You have to do whatever it takes in order to show that you attempted to save a life. So we are assessing the patient, we're giving them epinephrine, we're doing CPR, right? But there's no shockable rhythm. There's nowhere for the pulse or the joules to go on, hitch on to cause the electrical pulse to carry. So pulseless electrical activity, not a shockable rhythm. So now when that happens, there's nothing you can do, right? This person is gone. All right, let's move on to pace rhythm. So pace rhythm means the person's heart is not pumping properly. Atria might not be contracting. Ventricles might not be contracting. And so what we need to do is we need to put in a machine, the pacemaker, that's going to send the pulse and do the job of the SA node and the AV node. So if the signal is hitting where the SA node was, we know it is pacing the atrium. If it's going to where the AV node was, we know it's pacing the ventricles, right? So here is an example of A pace. This is an example of V pace, and this is an example of AV pace. A means it's a signal in the atrium, and here, this one pulse, which was captured, send the signal all the way through the heart. This one, it needed to help the ventricles contract, so it's sent it to the ventricle. And this one, because they are dissociated, the ventricles are working independently from the atria, we have to send two signals, one to the atria, one to the ventricle, in order to allow them to be in sync. So we talked about pace rhythms, then we have to talk about the spike. This is the spike we're referring to. This line here tells us that an electrical impulse has been sent, so it could be either captured or not captured. Captured means that the heart actually received the spike, the electrical impulse, and it produced a wave. Non-captured means it did not produce a wave. You don't have to cover the AV node. And that is the end of this here dysrhythmia 2. Next, we're going to look at hypertension. So hypertension is a big one. Hypertension is referred to as a silent killer. The main thing with hypertension is we want it to be SVP is greater than 120 and DBP is greater than 80. So SVP systolic blood pressure is greater than 120 and diastolic blood pressure is greater than 80, right? If we get two readings on average that are high, we say the person has hypertension. So rather, rarely symptomatic, person doesn't feel anything. Sometimes they'll have headaches and dizziness, but most of the time they won't feel a thing. But then something will happen and they'll die from a stroke or something like that. And by that time, it's too late. Our biggest other problem risk factors are damage to the organs, right? So we have coronary artery disease, heart failure, we have a person having a stroke, and we have renal failure. So all of these are things we want to prevent, right? We know that arteries are in every part of the body, the eyes, the mouth, the legs, the feet, the organs, everywhere. So if something is wrong with the blood vessels, it's going to affect everything. So these are the ones that we're most worried about. We're worried about the kidney, we're worried about the brain, which is stroke, we're worried about the heart, which produces heart failure and CAD. And it is preventable. We can tell them to manage their lifestyle, stop smoking, stop drinking, exercise, eat right, and that will help them. It's also good to remember MAP, mean arterial pressure. I'm not going to ask you to remember this formula, but it is good to remember. Know what affects blood pressure: viscosity, the thickness, length from the heart to the toes. It's a long length, diameter, whether you're going to have vasopressin or a medication that's going to vasoconstrict is going to affect the blood pressure. If you vasodilate, it's going to affect the blood pressure. Factors that affect arterial pressure, SNS, sympathetic nervous system, which causes stimulation, fight and flight, oh my gosh, anxiety. RAS system, which causes aldosterone to increase, and it causes angiotensin to aldosterone to increase or decrease, which causes salt to increase or decrease, which water follows salt, that increases or decreases fluid. And then that's aldosterone. And then we also have angiotensin, which is affected, where angiotensin comes from angiotensin 1, which came from renin. And eventually we get angiotensin 2, which is a vasoconstrictor, and the vasoconstrictor either decreases or increases the vessel, and that causes pressure to increase or decrease. And we talked about the hormones that are secreted that sends a signal to what the body needs to do at what time. Talked about the primary, secondary. We said primary, we don't know what's causing it. Secondary, we do. And if we could get rid of that problem, we'll get rid of the hypertension. Hypertension crisis, we don't want the person to get there. That is when the blood pressure is super high and it's so high that it's becoming a serious problem. It happens really fast, and we don't want this to happen at all, right? So you can definitely read over that. More on hypertension, modifiable factors, sodium intake, you can decrease that. Not eating canned foods, not eating salty foods, change the diet, lose some weight, don't drink alcohol, don't smoke, maintain insulin compliance, like if you're type 1, or if you're type 2, taking your medication so that you can decrease the glucose in the blood. Also decrease your amount of stress, whether it's at work, whether it's at home, whatever. Non-modifiable, we can't help it. And the biggest one we talk about is African-American males that get more affected by this than other races. But also age and genetic is an issue. Intervention, what are we going to do? Well, we know that the system is affected, the whole body is affected. So, and we know which organs are most prone to being damaged. We said the kidney, we said the brain, and we said the heart. And we also said the eyes. So with the eyes, there's blurred vision. So we're going to tell them to constantly visit their doctors, keep up on their eye check, make sure that they can see. And if they notice any blurred vision, anything happening, to get it resolved or fixed or looked at right away. Also headaches and chest pains. We're looking at dizziness, nosebleed. Those are some things that we will be able to see. We're educating them on how to eat. We're educating them on how to behave. We're educating them on what to look for, right? We're measuring their blood pressure constantly, making sure that they're keeping up with their medication. We're checking their medication. We're reporting whether they have high blood pressure. We're checking whether they have sensory issues. Do they have neuropathy? Do they feel on their toes, their fingers? We're checking all that. We're also looking at the medications that we're taking, right? We're taking contractility medication, beta blockers. We're taking ACE inhibitors. We're looking at thiazides, loop diuretics, all these things. You want to be aware of what they do, right? The diuretics we know reduces the fluid. Beta blockers we know helps with contractility. Thiazide also help with diuretics. So just know at least one medication under which one that we're talking about, whether it's enalapril, whether it's a beta, a Tylenol, whichever one you're going to focus on, you know what it's connected to, which categories under, so that you know exactly what that medication does. Again, we already mentioned this, problems we're going to see, lifestyle choices, medication adherence. Medication adherence is a big one because people tend to think, well, since I don't feel anything, I'm okay, I can get off the medication. It doesn't work like that, right? You have to encourage them to remain on the medication until their doctor tells them to get off. Okay. Also fluid volume, making sure we're drinking fluids, but it's being flushed out. It's if they're on diuretics, they still have to drink water, but also knowing that it can accumulate, they'll have edema. So we need to be able to assess that as well and know what's happening. And that is hypertension. Okay, and the last point is on peripheral vascular disease. And all of what we mentioned kind of worked us towards this, right? So we know that the blood vessels are affected. Many things affect the blood vessels. We talked about it. Here we have atherosclerosis, right? Plaque being formed in the lining of the blood vessels. That is going to affect how blood flows through this vessel, how blood is received at the extremity of this vessel, right? And it will affect mostly the arteries with plaque, but veins can also cause problems too, because we have valves that may not work properly. So here are some pictures that you need to remember. So the main thing for arterials, right, arterial disease is the pain, the intermittent claudication that we mentioned, decreased pulses, numbness, right? Those are the main three ones that we want to look at, in the ulcers too. The chronic venous insufficiency, we want to look at the edema. We want to look at the itching and also the ulcers. Well, they both have ulcers, so we want to stick to what makes them different. Here also we have varicose veins. That's part of the edema as well. Here's what that looks like. Here's the intermittent claudication that you can read. Risk factors, we're looking at smoking, diabetes, hyperlipidemia. They're all very similar, right? And as long as you know that, you'll be able to remember them all, right? For arterial disease, we have these issues. For venous insufficiency, we're looking at these, especially smoking, right? And it happens to females over the age of 50. We're looking at that. Diagnostics, you can go ahead and read through them, just being aware that these are the kinds of diagnostics that are used in order to identify if there's a problem with the blood vessel of the leg, if we don't hear pulses, if the person's not getting enough blood flow to the toes, they're not having sensation. These are the things that they're going to do in order to define or identify if they have an arterial issue or a venous issue. Here's the ankle brachial index. Now for treatment. So for treatment for arterial disease, we're looking at pharmacological treatment. So we mentioned aspirin, we mentioned Trental, which decreases viscosity, Platel, which is a platelet inhibitor and vasodilator. But we also have non-pharmacological things that we need to do as well. We're not going to compress, right? We're not going to use compression because compression is for valves. We're going to take care of the feet, make sure they wear white socks, make sure they don't put lotion between their toes, make sure they don't cut their own toenails. We're doing the same thing that we would do for a patient that has diabetes. Then we have valvular issues. What are we going to do? How are we going to treat them? We're going to treat the relief. We're going to help promote circulation. We're going to look at the skin integrity, and we're going to use compression stockings. Compression stockings are used for veins, for valve issues. What are the potential problems we're going to see with both? Poor blood flow to the peripherals, acute pain, skin breakdown, poor ambulation, fall risk, impaired feeling to the feet. And that is the end of our review. That is what you need to focus on for the exam. I've already given you the breakdown of what you're covering. And best wishes on Wednesday. I'll see you guys then. Bye.